AI. But I think that there must be some dark sides about AI because we are talking about healthcare and the cost of mistakes are enormous. So we will have some problems with application of AI system if it went wrong. All right. So what I'm concerned is about in the healthcare system, what will be the difficulties in implementing AI applications, as well as the expertise and the knowledge we could have to solve the healthcare problems. I don't know how about you guys, but in the US, but as far as I know, an AI PhD will get an offer as $1 million annual salary. How could your hospital can get AI expertise into your system? I don't know. For us, we even have difficulties in hiring AI faculty members into our universities. I don't know how about university will do, but we do have problems in hiring AI PhDs. So first one, so lack of expertise. How would you really implement good AI system to help you? Because those AI PhDs, they go to OpenAI, they got over $1 million a year. They go to Google, they go to Facebook, they're all the same. Okay, so I don't know how do you solve this problem. And also because the cost of mistakes are so high, so what could we do to prevent the problems from happening? That's the concern that we're going to have in the next panel discussion. Okay, so I'm not an AI expert nor a medical expert, so we just start with our panel discussion. All right? Okay, shall we?
Sure. Okay, thank you. Thank you so much, Dr. Tang. Now, please kindly take your seats first as I'm going to welcome all of our panelists to join us on stage. So first of all, yes, please, Dr. Stephen Han, former commissioner of the U.S. Food and Drug Administration and CEO of Nucleus Radiopharma. Please join us on stage. And also Dr. Mark Rosenblatt, Chief Executive Officer of University of Illinois Hospital and Clinics, and G. Stephen Irwin, Executive Dean of College of Medicine. And also Mr. Rodolphe Cottrell, please join us on stage, Global Chief AI Officer at Medtronic. And once again, please welcome Dr. Zhong Renyu, President of National Taiwan University Hospital. And also Dr. Wen Shiwei Huang, Chief Central Superintendent of the Shouchuan Healthcare System. Please join us on stage. Okay, so welcome our moderator and all of our panelists. And right now, Dr. Tan, the floor is yours.
Okay, first, that because Dr. Wang is the only one who hasn't spoken yet. So could you tell us, can you spend 5-10 minutes about how you're going to use AI in your hospital from a superintendent's point of view?
Okay, well, before I do that, maybe I introduce myself. So my name is Wayne, I'm a surgeon, and I represent the Shouchuan Memorial Hospital Group, which is a private hospital group in Central and South Taiwan. And we have been servicing rural communities for the last 50 years. And now we're trying to expand to Southeast Asia as well. And another interesting project that we have been doing is operating a minimum invasive surgery training center called the EarCat Taiwan since 2008. So we've been training surgeons from all over Asian countries, and we train about 2,000 to 3,000 people per year, and train over 20,000 surgeons from Asia Pacific region. So through this efforts, we noticed not just the Taiwan problem, but also the lack of access to safe, affordable care in all these countries, and how we could leverage AI, robotics, telesurgery, all these fancy technologies in these countries. And just one simple example, one perhaps the most common surgery a surgeon do is cholecystectomy. The most feared complications come about of injury, which is the rate is usually 0.1 to 0.2% in the developed country or in the well-trained hand. But I was told by my Philippine colleagues that the rate is 10% in Philippines, and they have been trying very hard to lower that with efforts of workshops, symposiums, hands-on teachings, and they have been able to lower it to 5%, which is still 10 times as high in any developed nations. And so I recently did several local workshops in Indonesia, and the rates are not reported, but I think I bet as high as 5 or 10% in these countries. So I think the possibility of using AI and robots in surgery and therapies is enormous, especially in Asia. I think Taiwan is well located in the central heart of Asia, with easy access to many countries. So we've been kind of a hub for training and for testing products coming from Taiwan or from other countries, US, Europe, and then deploying these technologies to Asian countries through in one part to my training center. But I think to answer First Tang's question, how technology can be utilized, I think it has a great humanitarian effort in using, I think, not just to minimize costs, but also to leapfrog the very huge lack of safe access care in many locations that doesn't have, I think was mentioned previously, it doesn't have surgeons, doesn't have any facilities, and if we could put in some technology that's affordable, and we can really offer this good service. So I think that is an angle that I would take on applying these technologies.
Okay, thank you. We all know that transformation is not easy, and we talk about the AI in transforming healthcare. So the first question regarding Dr. Heng is about everybody complains about the difficulties in using AI. The first thing they talk about, regulations. Okay, from regulatory point of view, what would be the major obstacles in applying AI in healthcare?
Yeah, I think this is a really interesting topic and something that I've been thinking a lot about, and that is, and I'm not sure if this is a global regulatory issue, but regulators in general of medical products don't regulate the practice of medicine. They regulate the ultimate use of medical products.
Yes.
And the question that you raised earlier is the most important one, because ultimately the regulators are about assessing the risk-benefit of any intervention. And so if you talk about the use of AI, let's just use an example, well care, and going to the homes and monitoring and influencing physician decisions. That is a well-trodden pathway at the FDA, for example. If you're providing clinical decision support or information that a doctor would use to make a decision, that's one thing. If, however, you're providing the care without necessarily having the direct involvement of a provider or some sort of oversight of that, that's problematic. There is not a regulatory framework at the US FDA to actually regulate that component of it, because again, by statute, not to regulate the practice of care. That will change, and it will have to evolve with time, because we will need to make sure that any medical devices, interventions, whatever, that we would look at the FDA, that there's appropriate risk assessment of that, and that you're not decreasing the quality of care. So there needs to be, number one, a change in the regulatory framework around this. But I think it's doable, and ultimately the challenge for developers of these products will be, how do you ultimately compare to what is currently standard to allow the FDA to make a decision regarding the risk-benefit? How do you know that it's better than the interventions you have right now?
So do we have any evidence so far that AI can outperform physicians?
Well, we certainly have exam results. I would argue that maybe exam results aren't the best way to determine that, but it's a pretty good start. I think we do. I mean, I would say that there's data on assessing radiographs and skin lesions, et cetera, that show pretty good performance, and we just saw a presentation from the folks at NTU about this. So I think we do, and I think that will evolve. The question is, when you take that leap from advising a physician and saying, yes, I think this is a basal cell carcinoma of the skin, to I'm going to make the decision to cut it out and then send the patient to the robot to cut it out. That's going to be the more difficult step. I think it will happen ultimately, but what's the oversight? And I think Dean Rosenblatt will have to talk about that one. And then also, what are the regulators going to say with respect to approving that when that ultimately becomes the practice of medicine? To be determined.
Okay. Dr. Rosenfeld, he gave you the question.
Well, I'll start by saying I don't think AI is just a tool like a stethoscope is a tool, or like an echocardiogram or an MRI. Very advanced tools, but you're actually asking or allowing AI in some cases to make decisions, and that has fundamentally in the past been the authority, the purview of healthcare providers, including physicians. So if it's decision support, I think yes, it still rests upon the physician. If it's decision making, then it goes into a new realm for which I don't think we have good answers. And there's ethical problems potentially. Certainly physicians are worried about their job security. But yeah, there's certainly regulatory aspects as well, all of which are frankly unanswered. I don't necessarily have a single answer, but I do think that there is shared responsibility from the companies that create the AI algorithms, and to make sure that they're testing them in the right way. Certainly regulators will have to set up certain standards, and then also physicians themselves to make sure that it reaches a level of security. But I do think there's something we don't talk about enough, because it's frankly very uncomfortable to talk about, is that the number of medical errors that humans make are profound, right? And in idealized clinical trials, they make fewer errors because of how regimentized it is. But it was discussed earlier how slow, well, it wasn't directed, but how slow we are even to take evidence-based medicine as physicians and turn that into reality in terms of the care that we have. So it may be that the standards to which we are trying to hold AI the bar is a little bit too high, given the number of errors that physicians make routinely. Now, then we need to, again, test AI in the real world. It can't just be how we test AI in clinical trial. I guess maybe human doctors and artificial, doctors, let's call them AI algorithms in a clinical trial setting, you compare them. That's what regulators tend to do. Then when you take that into the real world, how does that really also so I think that is probably the next step in terms of understanding how safe or unsafe AI is in an unsupervised modality.
It's very much like automotive driving. Yeah, people make mistakes, but with AI you cannot make mistakes. If you are auto driving a vehicle, you are supposed to be risk-free and error-free. Yeah. Okay. So, Dr. Kendra, do you have any comments on the difficulties and?
Yeah, I mean, I love that this was raised by a physician, because I've always been accused of being a technology geek. So, yeah, we hold the AI to a standard that we don't hold humans to, which I'm not saying is wrong. It's just it's important to measure the outcome of the combination, the outcome to the patient, the outcome to the healthcare system, and so on. So as long as net you're doing more good than harm as part of a risk benefit, that should be part of the equation. But that's not how the regulatory frameworks are currently constructed. We approve a solution independent of how it ends up finally getting used in the real world. And then the clinical trials are designed with our randomized clinical trial centers that are prospective. Typically, these are top performing centers with top physicians, knowing that they are participating in a trial, even if it's in a blinded fashion. So the level of care is usually above what you typically see in a rural hospital or when you deploy a solution to the wild. So I think if we want to think about the use of AI on the population level with healthcare as ubiquitous as healthcare delivery is, and as disparate as the care delivery is, that's the way to properly measure things from at least an industry perspective. Now, we say AI and we jumble things up a little bit, so maybe it's worth mentioning, and I think this was alluded to a little bit by Dr. Han earlier, there is algorithmic AI that is something that's been going on for 40, 50 years. So AI is about 85 years old, since World War II, so rule-based machine learning and deep learning for algorithms, let's say in a pacemaker or a defibrillator that makes a decision to shock a patient, that's technically under the rubric of AI. We don't think of these solutions as, oh, this is a robot or an AI deciding when to shock a patient, when to restore health, when to pace a patient. But those happen all the time. Now, those are regulated solutions. They are locked, they're not adaptive, they don't have a performance drift, the sensitivity and specificity is well known. When you start talking about generative AI, that is unregulated currently, and that's where you have hallucination problems. They will be solved over time, but this is the current conversation we're having. We're mixing modern AI defined as the generative, the agentic, the biased implementation with the AI we've been doing for the last 40, 50 years, which is more algorithmic, more defined, and locked. So I love that we're having a conversation around the final outcome, the final performance, but it's also important to have that nuanced conversation around not all AI is the same, and appropriate level of regulatory framework adaptation to the right type of AI is, I think, a more nuanced conversation to be had.
Okay, for Superintendent Yu, do you have any reservations about pushing AI all through your organization? What reservations do you have in implementing AI? Because as we talk about, AI is not perfect, all right? And it's only 3 years, large language model is only 3 years old. And I heard that the OpenAI may stop advising healthcare problems starting next year. So because they may be sued for their mistakes, all right? So giving out some reservations from even the AI, OpenAI, and without the physicians I know, what would be your reservations in pushing through AI through your hospital?
Yeah, as I have some example that using AI tools that know for AI for diagnosis is not perfect.
Yes.
So it's still about 80 or 85% accuracy. However, this accuracy is better than human.
80, 85
You know.
is good enough?
Yeah, it's better than human. But human, with AI tool, human can raise up their accuracy. They are system. They are very competent assistant, but they cannot replace human doctor because it's not 100% accurate. So you cannot depend on AI alone. So why it's better than human that from a success rate that when you compare 2 or 3 radiologists, that the consistency the consensus between them are always 50 to 60%. But for AI, it's 85%. It's not 100%. So you use 3 AI tools to interpret one image. So you can get a consensus, and with that, doctors can still need to review the image and make the final report. So if you want to push the AI tool to the hospital, that I think the way of practice is the same. So you still need a human doctor to make the final decision. However, with AI that for if the AI is used for a daily habit or daily behavior, like you use AI to scan your food to see how many calories that you have, I think the AI can use that because doctor cannot make it. So for this application that AI can be used without human, but if you are approaching a diagnosis or treatment decision, then cannot. The doctor should be there.
Okay. As you are the largest one, the most prestigious hospital in Taiwan, when you push through AI through your organization, what difficulties do you face? Because not every doctor will, first, it's not in their education 20 or 30 years ago. AI is not part of their education. Now you're going to push through. What kind of problems that you're going to face, and how did you do it to overcome those obstacles? in pushing through AI through hospital?
And one is that doctor actually can divide into two generations. One generation that they don't
Like me, right?
trust AI, right? so like superintendent. But for the young doctors, actually they are lovers
Oh,
of AI.
okay.
So when we start our digitization of medical record, we start from medical students and young doctors. And when they use the digitized electronic medical records, their teacher, the professor, they have to use it because they have only one choice. So the doctors. So we start from our young doctors. They have needs. So they are very accustomed to use computer and to use computer program that. So they are many wise or clever doctors, smart doctors. So we started that we push them into the AI office, and so they start to generate their ideas, their needs, and to make many programs. But for all the program, they're still under one principle that they start with research. So they're under IRB, they're under ethical control. So the hospital will make the final decision whether this one will go to the clinic.
Okay, you have a safety check. This question is going to for Rosenberg is that we know that AI is smart, but will make people stupid. With you rely too much on AI to make decisions, and then you don't think anymore. You don't have to memorize all the bones. You don't have to memorize everything for a medical school student. That's the reservation I have for using AI in medical education. How do you solve the problem? Because if we used to have, we used to remember all the calculations. Now we have the calculators. We don't have to. We used to go follow the map. Now we have GPS. We don't have to learn how to read the map. So next one, if AI can write compositions, we don't need to know how to write. So for educator, we have the kind of reservations about pushing AI through our education. How do you think?
It's a very provocative question. I like it. I'll start by saying the genie is out of the bottle, and that this movement is happening. So the question isn't if it's going to happen; it's how is it going to happen? How do we use it appropriately? Go before calculators. There's something called a slide rule. I don't know how to use a slide rule. Maybe my father did. Then I used a calculator, and etc. So there's some bits of technology that can become outdated, and we move on. And there are other things we have that augment our ability to work. So I'd like to think that AI, and particularly some of the generative AI, agentic AI, might be freeing for physicians in a way to allow them to actually be doctors again. So at least my experience has been in the past 10 years that when I go to a physician's office, I spend more time looking at a physician's back as that physician is typing things into a computer than I actually experience interacting with that physician. And they're working an electronic health record system, which frankly was designed to optimize billing and collections, not health of patients. Okay, so how do you free up physicians to do the things that physicians are really good at, the human part? We don't yet have computers that can understand well the social situation, the psychology, the lived experience of a patient. Maybe that will come over time. But we have computers that are really good at reading every bit of literature and synthesizing that. Something that, frankly, there's so much literature. I'm a corneal surgeon by training. I can't even keep up with the corneal surgery literature, let alone all of the literature in medicine in my subdiscipline. So, computers will help us synthesize large amounts of data. A patient comes into the emergency room in the middle of the night, has hundreds of pages of records, and you have to make a decision about the care of that patient in a matter of minutes. You need a computer helper to help summarize as best it can that patient's medical records, so you can make decisions sooner and better decisions. So they are going to be companions, not replacements, I believe, in the short term. There'll be some parts of our jobs that they will replace, other parts they cannot replace, and some parts that we're going to work together in a concerted way. So we're trying to shape our medical students' experience in a way that they are very comfortable with the technology, They understand what it should replace, what it shouldn't replace, and how it can make them better doctors and interact with their patients in more meaningful ways.
So do your medical school students still need to remember a lot of things, memorize on the human body structure, all the bones, all the nerves? I like a memory machine for a doctor, from my point of view.
I would say that the amount of knowledge that in theory they need to have access to exceeds the amount of knowledge that any human being can internalize. So there's a certain amount of information that they need to access that's going to not be retained in their own brain. However, a certain amount of fundamental knowledge is required to interpret the answers that a computer would give. If you don't have a certain understanding, like where's the liver located, or how does, what are the different parts of the digestive system? If you don't know that, the output of a very complex machine you won't understand how to interpret that. And obviously that's the issue, is there needs to be a fundamental framework on which you then plug in the machine inputs to then lead to better care for patients. What the subset of things they need to know and don't need to know, that is fertile ground for research, right? That is a really important question that we're just really grappling with. Again, our medical education department is really in the thick of it, trying to determine the answers to that very question.
Yeah, we are facing the same question. Do you have an answer? You don't. We are also facing the same questions about how much do we teach our medical school students? Yeah, and what need to be taught, what need not to be taught. All right. Okay. So now for Dr. Wayne. So we're giving all the benefits of AI. So so you want to realize all those benefits, but you have to push through your hospitals. So what did you do? Because those who were not in the doctor's education before.
Yeah, I've had an experience of running an accelerator program with a partner in Taipei, and we run through 150 companies, invest in dozens of them, and the experience of trying to guide the companies in the hospital usually is that the senior surgeon, like was mentioned, the senior surgeons are like, oh, I don't need AI. I'm as good as AI. I have 100% accuracy. It's only for the juniors. So I guess that's part of the reason why Superintendent Yu, usually we start with the young or the more junior who are more willing to experiment and generate data. So I think when we try to guide the teams, the startups into the system or to the market, I think it's important to find the willing adapters, generate data, and then in turn can try to convince. And for the more senior team, I think we need to create a culture of innovation. It's not whether it's going to help you or not, because for people who have been practicing for 30, 40, 50 years, it's sometimes hard to change their workflow. Usually AI modifies a little bit the workflow. They have to adopt a new way, push a couple of new buttons, and that alone can be annoying to people. I think it's a complex process to guide, to change a new product, a new workflow into the surgeon practice. But I think you have to have a new culture of innovation within the system, and for the companies, just have to find the right person to adopt and generate data. So one example is we have a portfolio company that is using, use the AI to generate 3D information and in the colonoscopy. And the most important indication of quality is adenoma detection rate in colonoscopy. So we ran a randomized trial in National Taiwan University, showed that the ADR is increased by 80%. So now that generates a lot of interest in endoscopists of all skill levels. So their interest is to see more how this can benefit the colonoscopy quality.
Okay. So another question I have in mind for all of you is that we know that AI could be applied in healthcare. So where do you start? Because you talk to artificial intelligence people, they don't know healthcare. Tell to healthcare people, they don't know AI. So what would you do? How to combine them together?
Well, I mean, your point about OpenAI hiring AI PhDs for $1 million is a really good one, and so that's part of the problem, right? If hiring the people to your healthcare system. But I think, and I'll just speak from the regulatory point of view, what I believe the FDA is going to do is to borrow from the private sector, and there's a precedent and there's a legal statute that supports this, to borrow that expertise and to use that expertise from the private sector to enable what their job is. So I don't think they need to build it internally. I don't think they need to pay them $1 million, but I think that they could borrow that. And there's lots in the private sector that are willing to develop those algorithms. I just want to jump onto one thing that I think Dr. Katra and Dean Rosenblatt said, and that is I don't think the regulators are going to say the perfect should be the enemy of the good. I don't think that's going to happen. It's going to be compared to what we have. But your point about the fact that it's broken now and it's getting worse and the accumulation of data is making it more difficult, that this is a solution that absolutely has to come. And we don't really have a choice as the workforce decreases, the complexity of care increases, and the data information is there. What we have to find out is how do we do it in a way that's as safe as possible for everybody.
My question is whether you want to train health providers to learn AI, or you train AI people to learn healthcare. So which role will be more efficient or effective?
Well, I'm no expert, and perhaps you can speak to that, but I think you need both. For me, from a physician point of view, as I think about what you were saying, Dean Rosenblatt, is that, the doctor has to understand how to interpret the information that's coming his or her way. That's the bottom line. Do they need to know all about the underlying algorithms? Probably not. But as data comes and is summarized, they need to incorporate that into their decision making. To me, that's what you teach. But a rudimentary understanding is probably important. But I'm no expert. So.
I would just add, and I've said this often about engineers in the past, is that engineers have solutions looking for problems, and physicians have a lot of problems and they have no solutions. And by having them work together as teams, you can actually be quite effective. Now, it doesn't obviate the fact that it's very expensive to keep folks who have expertise in AI interested in academia. I will say the mission is important. There's a subset who want to be in a place where they know they're making a difference and working in the academic environment. We have the freedom, matters more than the cash, because they still are well paid in academia, just not at a $1 million level. That being said, and we've created those multidisciplinary teams, as I mentioned, in the center that we have, where we have card-carrying AI, algorithm writers working next to physicians, working next to some clinician scientists who kind of have their foot in both camps with others. But I think this underscores perhaps the increased need for there to be collaboration between academia and industry. Because industry can afford to hire the folks, but they also need to find the expertise. And it's very hard for even the very wealthy tech companies, Verily, Google, to hire enough experts who want to leave academic medicine or others to join their teams full time. They need to borrow that or buy that expertise or collaborate, frankly, to get that expertise. And I think maybe AI, more than any other thing that's come forward, is going to require that kind of industry-academic partnership to really get the full benefits of the technology for the issues, for the medical needs that truly exist.
Yeah, I mean, look, to me, it's a translation issue. I don't know why we're singling out AI. People must not really like AI. So how many physicians understand how a CT or MRI actually works as a machine, but they trust the film? We've never said, oh, we need to hire our own imaging specialists in the hospital to understand how a CT machine operates. I mean, as long as it's explainable and validated and approved, it's a translation issue. The power of AI is if you make it simple enough and intuitive enough, and do the right validation and the right clinical evidence, Does every physician need to be an AI expert? I would argue no. But again, we're not saying to have an engineer throw out a solution and have the physician use it without. That's important to know. All right.
It's an engineering issue.
Yeah, I mean, it's a translation issue that needs to be solved, and it's a cooperation, I totally agree, between the AI developers and the medical community. But I wouldn't single out AI for that. This is true with every advancement.
Yes.
Robotics, endoscopy. I mean, how many of us know how a GPS works, but we trust it and we use it, right? So I'm a little more pragmatic about this than, I'm not saying I'm crazy bullish about AI. I think it has its role, but it's a tool. And as long as we know how to translate its application in healthcare without adding extra buttons, without adding disruptions to the workflow, there's opportunities to do a lot more good with it than not. And I don't want to lose sight of the patient here. We talk a lot about the healthcare workflow accommodation. I'll give you an anecdote. We work with a center in Australia. Some of the patients that I was fortunate enough to kind of work with live about 5 hours from the hospital. So on the day where they have clinic, they will drive, or a family member will drive them. So that's taking time off of work, driving your elderly parents. 5 hours to the hospital where they spend the whole day in the clinic waiting to be seen for 5 minutes when a physician looks at their scan, looks at their wound, taps them on the shoulder, says everything's fine, and now they have to go back 5 hours. When we looked at the performance accuracy of these physician checks versus an AI-based check, they are non-inferior. So the question is, even if there's no superior care in diagnosis, or if it's non-inferior, the cost to the healthcare system, the impact on the patient and their family to drive 5 hours to be seen and then drive back for 5 hours for an equal level of diagnostic yield, I would say I would trust an AI for that patient. It's not inferior. Now, if you compare that situation to a patient that has access to top-notch physicians in tier 1 cities, cost is not an issue, healthcare bandwidth is not an issue, then you'd say, yeah, if physicians can do the same thing, why use AI? But that's not what we're talking about. We're talking about a world where not everybody is receiving the same level of care, or in the future will not be able to. So we need solutions to help with that. And as a society, we need to decide how much do we regulate, how much do we want to put ownership on the AI from a validation clinical evidence, and how do we incorporate it into our healthcare system as it exists now, or as it's going to be in the next few years. So I'm a little more pragmatic about this, and I'd love to be that person who gets paid $1 million. I'm not. So if you can give me the number of who's hiring, maybe I can go there.
You look like 70 or 80 years ago in China, China had barefoot doctors. Those doctors get trained for 3 months and then take the box and go to the countryside. But there were no doctors at all. So that was the case, okay? But now we can make more democratized AI. But the problem is AI and GPS is different. First, AI has not come to the trust level as GPS. The second, the cost of mistake are so high than GPS. That's why, that's why I'm asking the question,
I don't know, I'm a scuba diver, and I do ice diving in Minnesota. My GPS told me, I drove on the ice on the lake so I can dive. And my GPS was telling me not a digitized road, and completely freaked out because my car was on water. So I would say, technology has its flaws. Technology does have its flaws.
Okay, all right. So Dr. Yu?
So still back to the question that for doctors and technicians.
Yes.
Okay. So most of doctors, I think 95% of doctors, they are users. So you only need to provide the AI tool for them or agent for them. So if they found it convenient and trustable, they'll use it. But we still need several and few doctors that know the other side. Especially most of the doctors are quite smart, and indeed that we have trained, we have sent our about 40 doctors to the AI school for class. So they are the foundation of our AI office. So these doctors, they know both sides, and they can communicate with technician. So with that, so we can develop the AI program for our own hospital. Yes, but I agree that for one AI tools that can be applied generally to our primary care, either physician or nurses, it's not easy. Especially this tool is to make for CDSS, for clinical decision support. But if the tool is only for workloading reduction, it will be easier because it's most of the first AI to make a medical record easier or make the workflow more efficient. They can bypass or they can skip or they can reduce some complicated data processing every day. So if that with this AI is more acceptable to the clinician and to the nurses, yes.
Okay, Dr. Huang, how do you acquire AI expertise? Giving you
Yeah, I agree with, I think, with the Superintendent Yu. I think not everybody needs to be, well versed in the AI language. I think they're end users. But as I mentioned, we need a cultural change in the hospital setting. So we do need to train, interested doctors. The language of engineering, perhaps even some business sense, about how a startup works, how to implement regulatory. So all these facets of a life cycle of an AI related startup, and then these people can be the catalyst of bringing change into the system. So, and I think for a majority of surgeons, doctors, surgeons, or internalists, I think they are users of the technology, the tool, pretty similar to using the CT, the robot. We don't know how it works, but if we don't learn, still it's a tool. Like if you purchase a surgical robot, if you don't learn how to use it, it's not going to do better than before. So if you have AI tool, you still need to have a training curriculum of how to use the data, the decision support that's coming out, and I think we shouldn't be so afraid of either the AI, because now it's generating decisions, but we shouldn't be afraid of it's going to replace us in the future, because there's a lot of examples, like I think the orthopedic robots is an example where they define already where you can cut the bone, and the surgeon just press a button, and the surgeon can't even go over the limits defined by the robot. So that is, if the AI gives you and I think radiation oncology is also the same. They define this place you should to ablate, and you just press the button. So I think for AI, they generate an answer and just press a button, and I think you have to make that pushing action, decide, and then take the responsibility. So I think, and how I think that's how I see, it can simplify surgeon or physicians' work and really give back the dignity, or we are so overworked by all this paperwork. So I think that's where we need to go.
Yeah, okay. Well, thank you very much for all your comments. I think for this morning, we talk about all the potential benefits from AI in applying to healthcare. However, because the costs are high, to realize all those potential benefits, we need cooperations from technicians, from regulators, and from medical education. But my primary interest on the medical education, because we have a huge medical school, we have to know what to teach and what not to teach. How do we use AI to allow our students to have become a better decision making in their clinical decisions later on. And also, we also need industry corporations to incorporate AI into devices so that we can really trust your devices. So, and the hospitals, we have to educate our young physicians first to learn how to use AI and hope that they will influence older physicians that they will be able also join the AI parade. So I think that's the lessons we learned throughout this morning. Thank you very much for coming. I hope that we have more conversations like this in the future. Thank you, Eric.
Thank you so much, our moderator and panelists. Please remain on stage, just rise. Let's take a photo together, and also like to invite Dr. Zhuang. Please join us on stage to take a photo together. 我们一起在舞台上拍一张 panel discussion 的大